Yeah, live, sir.
Okay. Good afternoon, everyone, and I thanks Shastra University, Dr. Swaminathan and Ms. Anuradha to invite clinical doctors to the the engineering aspect of the conference and all. And I feel that there has to be some kind of connect between the engineering part and the medical part, so that we can take up the technologies whatever is being developed. And if there are any issues with the specifically with the neurosurgeons or the spine surgeons, then we can bring our problems to them so that they can sort it out and we find a better way. So first of all, I would like to invite Dr. Ramesh to go ahead and present with his views.
Sir, I would like to welcome you all. Very good afternoon to one and all. So before Dr. Ramesh talks, I would like to, welcome you all for this virtual panel discussion on medtech opportunities in neurology on behalf of this ableist and Shastra. So there are series of sessions which are happening from yesterday in diverse medical field. So right from orthopedics to ophthalmology. So now we are in the fifth session, which highlights about the unmet challenges, especially in neuro field. So this event is organized as a part of a 75th anniversary of Indian independence with the aim to build self-resilient India, Atmanirbhar Bharat, with the technology-driven innovation. So from the first session till now, I had a good opportunity to listen the views of healthcare providers. So wherein one common point was discussed is the lack of connect between the medical practitioners and technology solution providers. So as a joint venture, Ableist and Shastra have attempted to bring the stakeholders, including medical experts, young innovators, and future entrepreneurs, on a common platform through this virtual panel discussion. So today with us, we have eminent neurosurgeons, Dr. Anand Nayak, Dr. Ramesh, Dr. Tirupati, and neurophysician, Dr. Ravi Chandran. So I extend my warm welcome to all the medical practitioners who are now on board to share their views in neuromedtech revolution. So this session is moderated by Dr. Anand Nayak, who is a renowned spine surgeon in India. He is a director, spine surgery, CK Birla Hospital and Medanta, the Medcity, Haryana. So Dr. Nayak strongly believes in and has introduced the concept of safe spine surgery with the mission of changing lives through excellence in spine care. Dr. Nayak brings a rich experience of more than 21 years, including his experience in first world countries like Singapore, Australia, and USA. He has introduced a few spine surgeries for the first time in India, such as a lumbar hybrid with second generation monoblock viscoelastic artificial disc replacement, extreme lateral interbody fusion, first team in Asia as well, navigated sacroiliac joint fusion, minimally invasive surgery for adult degenerative scoliosis, metallic titanium-based additive 3D manufacturing of spine parts and devices for complex reconstruction of tumors of the spine. He carries experience with the most recent mixed reality spine surgery using artificial intelligence and virtual reality, which is US FDA approved. Dr. Nayak also designed and introduced real-time robotic navigation of lumbar disc replacement devices, which is aimed at enhancing accuracy and patient safety in India. He also has numerous spine device innovations and patents to his credit. Thank you for accepting to moderate this neuro session. Hearty welcome, Doctor. This panel member, the first panel member of this event is Dr. V. Ramesh, who is a specialist consultant in Brain Spine Center, Trichy. With his 25 years of rich experience at this particular domain, he almost covered the full spectrum of neurosurgery. His experience encompasses managing head injuries, spine fixations for inflammatory and degenerative spine disorders, brain and spine tumor surgeries, complex skull-based surgeries, neurovascular surgeries, orbital surgeries, and pediatric neurosurgical problems. He is also managing trustee of Amen Trust, whose main focus is affordable neurocare. Thank you for accepting our invite, Doctor. A warm welcome. The second panel member is Dr. Ravi Chandran, consultant neurologist at Kaveri Medical Hospital, Trichy. He holds membership in various professional bodies. His special interest includes neurocritical care, neurosonography, and deep brain stimulation. Thank you for your participation, Doctor. We welcome you for today's event. The third panelist is Dr. Tirupati, who is a senior most neurosurgeon in Apollo Specialty Hospital, Trichy. He received various fellowships in neurosurgery in Japan, and he holds various organizational positions. He received fellowships especially in microsurgery, with skull-based microsurgery, neuroendoscopy, cerebrovascular surgery, stereotactic, and spinal surgery. Thank you for accepting to join as a panel member. Warm welcome, Doctor. So on the whole, I will take this opportunity to welcome you all to get more insights about the unmet challenges in neuro field. So I now request Dr. Anand Nayak to take over the session. Thank you.
Yeah. Thank you, Anuradha, for a very brief introduction of all the panel members. So may I now invite Dr. Ramesh to take over and enlighten us. Dr. Ramesh, please.
Thank you. Thank you, sir. Thank you, Shastra, for giving me the opportunity to interact and get introduced to all of you. And today, my topic of interest is, can you see my slides, please?
Yeah.
Yes. See, neurosurgery has taken a remarkable change in the last few decades. And the innovations in neurosurgery several innovations are happening. And since my time duration is just 15 minutes, I will just race through the remarkable innovations that have happened in the last couple of years. See, I focus on the hydrocephalus. Hydrocephalus is a very important neurosurgical entity that is very common in our day-to-day practice.
Doctor, can you please share the slides if you have?
Yes, sir. I am sharing the slides, sir.
No. Can you please share it?
Yes, sir. I will again reshare it. Is it visible?
Yes, doctor.
Visible?
Yes, doctor.
Yes. Okay.
You may click on that, doctor.
Yes.
From beginning, that's it.
Yes. So, first I talk about hydrocephalus. Hydrocephalus is enlargement of head that is happening in the pediatric age group, and it's a progressive increase in size of the head. And this is the CT scan appearance, which shows the collection of fluid. Why I am mentioning about this is the incidence. The crude statistics is India, it has got the highest incidence of newborn every year, and it accounts to 0.2 to 0.5 every 1,000 births. And in fact, in this large country, for managing this basic problem, hydrocephalus, you need this gadget. This is a hardware which is needed for performing this surgery. And this hydrocephalus surgery cannot be managed without the help of the technicians, and without the help of the technical advancements that have taken place. And in fact, in this large country, only one company is manufacturing this hydrocephalus shunt tube. There is only one country in this population in the country of a population of 100 crores. And this can be managed very easily with a ventricular peritoneal shunt tube, and it has got excellent results. And patients do well and come back to near normalcy, and they have absolutely normal life. And this is the second important innovation that has happened in the management of hydrocephalus, where you can see inside the ventricles using a neuroendoscope. This is the neuroendoscope gadget, which I am using. And this is you can see there's a space inside the brain called ventricles, and inside that ventricle there is a small membrane. And when you perforate that membrane using a tube, then the natural pathway is established, and patients become absolutely normal. But in this large country, there is no company which manufactures this endoscopy. If you want to have a neuroendoscope, you have to buy either from Germany or from United States or from some small country like Italy or like that. So this neuroendoscope has revolutionized the field of neurosurgery, and it has almost become a very, very important tool in managing neurosurgical problems. And without neuroendoscopy in this era, it is not possible to do a major chunk of neurosurgical problems. And this is the basic neurosurgical theater in this era. You know, this is full of gadgets. You see, full of gadgets, and you know, the remarkable neurolights, the remarkable operation theater, the remarkable other gadgets. And if you see the number of brain tumor surgeries in the last decade, at least statistically, it is increasing in number, and you cannot match up the increasing numbers by associated increase in the technological expertise. Without technological expertise, this cannot be possible. And you know, around 28,000 brain tumors are reported in this country. And but for managing these cases, you need remarkable technological expertise. And this is one of the important gadgets that is very, very essential in managing a neurosurgical problem. This is an operating microscope we are using, and this is this provides very high illumination and magnification of the field, and you can have a better delineation of the structures. And only because neurosurgery is a very complex field where we deal with very, very delicate structures which are a few millimeters in size. And a small damage to those structures can lead to catastrophic results. Sorry, yes. Yes, this is one of our patients, a spinal cord tumor which is operated. And but for this high illumination and magnification, it is not possible to do these kind of surgeries with good safety. And for our new performance, you need gadgets. But for gadgets, it is not possible, impossible. This is one of our brain tumors patient, a skull-based tumor, which we have been totally excised, which is one of our examples. And this is another gadget which we are regularly using for a precision neurosurgery. This is a high-speed drill which is used for doing a quick performance of the exposure of the tumor. And this is with this gadget, things are done very precisely and things are done very fast, and it's a very, very it decreases the operating time, and it can be our performance becomes more efficient. But unfortunately, in this country of 100 crore population, there is only one company which manufactures this drill. So this is where our technological expertise can improve, and technological expertise or associated support of technology can give us a good, make our job easier. And this is another important gadget which is used for neurosurgery. This is what we call as an artistic neurosurgery. Neurosurgery is something like the paintbrush of a computer or the paintbrush for an artist. By having this gadget, you can just suck out the tumor with utmost precision, and you can see inside a lot of technological innovation, which finally gives us a very good result without damaging the surrounding structures of brain. And neurovascular surgery, in the last 20 years, neurovascular surgery has become phenomenally expanded. It has expanded phenomenally, and the full credit should go to the technical innovations that has happened in neurovascular surgery. And neurovascular surgeries are kind of changes that is happening in the brain blood vessels, which can if these blood vessels burst, then it will lead to subarachnoid hemorrhage and brain bleeds, which can give rise to stroke and which can even produce death. And this can be managed by aneurysm clip, and by good surgery and by clipping these aneurysms, you can totally cure the patient. But this can be done only with the availability of these gadgets. And this is an intraoperative monitor, which is Doppler system, which is used for our intraoperative monitoring of the blood flow in the blood vessels. These are all remarkable innovations that give us a very safe avenue for doing these surgeries. You can see these are all the varieties of clip. These are all the varieties of clip that are used of different shapes, of different types of clip applicators. And these can be manufactured and these can be done only by a direct coordination between the doctors and the person who manufactures. And in fact, in Western countries, all these neurosurgeons are adopted by different company people, different technical people, and they interact and they design these kind of clips for the aneurysm, different shapes of the aneurysm, and thereby providing a very good, safe tool to perform the surgery with utmost precision. These are a few of our aneurysm patients whom we have operated in the last few years, and these are all possible only because of the good technical innovation. And these are all other innovations that have happened in aneurysms that has taken the whole world in a different way. These are all called the endovascular procedures that are happening in brain surgeries. And these endovascular surgeries are highly minimally invasive surgeries. And these surgeries are possible only because of the technical innovation and the new changes, the remarkable happenings that has happened in from the technical side. And these are all the high quality flow diverters, coils and stents that are used for occluding these aneurysms. And these are some kind of patients stay in the hospital for just 2 or 3 days and they go home, they walk back home. And why I am reiterating these things are, none of these gadgets are produced in India. None of these gadgets are manufactured in our country. And in a country of a population of 100 crores, we are not producing even a single flow diverters, single coils. All these things are purchased from countries like Germany, Italy, and all those countries. So this leads to a lot of increase in the cost of the gadgets, and thereby the whole cost of treatment increases. So in a huge country like ours, with the innovators and without great entrepreneurs and great technical people like this audience, if they sincerely understand this lacuna, definitely they can plan for manufacturing these kind of gadgets. This can be made available, all these gadgets can be made available, like this image guidance system, which are very much essential for high precision targeted, where you can reach the tumors by a minimally invasive craniotomy and you can reach the lesion. And this is another recent developments that are happening in neurosurgery, which is called virtual reality in neurosurgery, where you can have an image, you can have, using these gadgets, you can pre-operatively, you can visualize the lesion. You can see how the lesion will look like once you expose the brain. And without performing the surgery, you can have a pre-operative guidance about how the lesion will look at and what are the complications you can expect, what are the important structures that are around, and how you can safely perform this surgery. So all these gadgets, all these new innovations are targeted only to improve the safety of the surgery and only to reduce the complications and only to provide a very good care. And all these things are not possible without innovations. But for innovations, all these things are impossible to do. And to summarize, innovation is the key for neurosurgery, and all the technical advancements are mandatory. They are not luxuries. When we passed out, operating microscope was a luxury. But in this era, you cannot do a neurosurgery without operating microscope or neuroendoscopy. So all these innovations with adequate learning, thanks to all these internets and Zoom meets where we can virtually go in and see the surgeries being done in different parts of the world. I can see the surgeries done by renowned neurosurgeons from America or renowned neurosurgeons from Japan online. Daily, every time when we go and operate, we watch several surgeries beforehand. These things are not possible a few years or few decades back. All these things are done now. All these things are at our doorstep. But for these innovations, these things cannot be done. And with the cooperation of our team, our co-neurosurgeons, our associates, our staffs, and the innovators like you, and all these important advancements, and having these gadgets at our doorstep, because it is not easy to have all these gadgets, because it costs a lot of money. And by having all these things manufactured in our country, will remarkably reduce the cost of treatment. And by taking all these maneuvers, we can provide affordable care. Our aim is to make healthcare, sophisticated healthcare, reachable to poor population. That is must be our goal. And only by having these innovators with us, and only by having the support of everybody, we may be able to do this. And this comes only by association, and this comes only by all people like you. So with this juncture, I conclude my topic. Innovations are the key, and that is the lifeline of neurosurgery. And all these innovations will make us give us safe, affordable, good care to our beloved patients. But for them, we are not here. Thank you very much.
Thank you, Dr. Ramesh, for sharing your experience and a wonderful presentation and basic instruments and the basic need which you have. I hope the engineer are taking down the notes, and they will be in touch with you to develop some of these basic, simple, products, so that the cost of care should come down, and it can be easily available, made in India, and can be used for our countrymen. So may I now invite Dr. S.P. Tirupati to share his experience and his knowledge with us.
Sir, the next actually Dr. Ravi Chandran.
So you want to ask some questions?
Yeah, we will do it at the end.
Okay. So can we go ahead with the rest of the part of discussion?
Yeah, that Dr. Ravi Chandran will be presenting now.
Okay. So I'm really sorry. Can I call Dr. Ravi Chandran to? He's a consultant neurologist at Kaveri Hospital for his presentation.
Good afternoon. Am I audible, sir?
Yeah.
Good afternoon, everyone. I'm going to talk briefly about electrodiagnostic assessment of imbalance. Since I'm talking to a non-medical community, I'm compelled to introduce to the topic of imbalance with few slides on how our body is maintaining the balance. Imbalance as a medical symptom means a disturbance in the spatial orientation of one to the self or the surrounding. This is a famous illusion most of us would have seen. You just stare at the black circle in the dot. The lines, the color lines around the circle appear to be moving. This is a very famous illusion. Most of us would have seen it. And this is what exactly the patient feels. Patient reports spinning sensation of head or the surrounding. This is what we call as vertigo. Most of us would have experienced vertigo as a children, or we can experience it now. If you want to, if you spin around in a place and abruptly stop, you will experience the sensation of what vertigo means to us. I'm insisting on this point because for most of the physicians like us, and only when you experience a symptom, or only if you understand the symptom, you will be able to approach to the diagnosis of the symptom. Unfortunately, the evaluation of disorders of balance are challenging because most of the symptoms reported by the patients are not experienced by us, are not easy to understand, and in fact, some symptoms patients are also not able to describe. It's not just the vertigo, there are other symptoms which are difficult to understand. Includes patient may report sensation of the body is tilted or the environment is tilted, and other group of motor symptoms that patient may report are they have difficulty in sitting, standing, or walking. They can report fear of falling, a tendency to fall. So imbalance is a quite challenging symptom for a physician to evaluate. Even in medical literature, most of the different authors give different heading on analysis of the imbalance. Some people headline this topic as approach to dizziness, approach to giddiness, or approach to imbalance, approach to unsteadiness. Fundamentally, when we encounter a patient with a problem with the balance, we try to group them into either one of these three symptoms. The first one is predominantly a rotatory sensation. The second is something that is non-rotatory, but still disturb the patient. Either this could be a swaying sensation, or this could be just an unsteadiness in walking. And third group of symptoms is predominantly a cardiac symptom, but in terms of description, there's a considerable overlap between this symptom and the above two symptoms. And quite often, most of the patients report more than one symptom. We need to base our analysis, our diagnostic approach based on the symptom, because that's how we list and prioritize the clinical test and the laboratory investigation and other advanced investigation. And we also have a fourth group, which is non-specific giddiness, which simply means that we don't understand the patient's symptom. It happens quite a bit of time. And I briefly elaborate on imbalance and systems in the body that's maintaining balance, and clinical and electrodiagnostic tools used in the assessment of balance. Imbalance, if you look into the statistical aspect of it, because of the wide experience or description of symptom, patient end up seeing a neurologist, a ENT surgeon, or a general physician. If you look into the lifetime prevalence of significant dizziness, this is not just any dizziness, dizziness that's affecting the patient, causing suffering, is 70 to 30%. That's quite a significant number. If you work out the maths behind it, if you even take it to a modest 20%, for a 750 crore and odd population in the world, at least 150 crore people living now would experience dizziness in some part of their lifetime. So there's a huge population that needs to be served. Contrary to the popular belief that unsteadiness is a problem of the elderly people, it's actually, most studies show the common group that is affected is the people of 41 to 70 years of age. And another popular belief is imbalance is due to the inner ear problems. But actually, studies again here show 42% are not peripheral vascular problems. And one more difficult issue regarding this is 1 in 6 patients has 2 diseases that is causing dizziness and at the same time. So when we see giddiness, the common group of diseases that is causing giddiness are generally peripheral vestibular accounting for 40% of the dizziness, central vestibular. This is very serious problem which always we look. Most of the clinical analysis and the initial laboratory or technological analysis, we try to identify this particular group of dizziness, central vestibular, caused by lesions or diseases of the most vulnerable and important structures of the body, the brainstem and the cerebellum. And others, which include several other causes, account for 20%, and psychiatric diseases contribute to at least 15%. And even with whatever the technological advancement, we still don't know the cause for giddiness in 10% of the population. So this points us to the need for a good technological support to analyze, to diagnose a patient with imbalance. Apart from the causes of the giddiness symptom of imbalance itself can cause a lot of mortality and morbidity to the patient, causing injuries, hospitalization, and death. And falls should not be underestimated, because 33% of people above 65 years of age fall at least once a year. It means 1/3 of the people more than 65 years fall at least once a year. And this 25% of falls results in a fracture, which can lead to serious consequences in the elderly population. And this is one of the major causes of accidental death in people above 65 years of age. So this is a very serious problem where we don't have any diagnostic aids. So looking very quickly into the balance system of the body, our balance system has a sensory pathway and a motor pathway. Our brain coordinates the sensory inputs from the vision, and most importantly, the vestibular apparatus, and sensation from the muscles, joint, and the cutaneous receptors. And these signals are integrated in the brain. And when a movement is planned, the sensory integration happens in the brain, and neural command takes the support of the cerebellum, and it is delivered to the motor output, and it's monitored real time. That's how balance is achieved. So, for sure, this is the largest anatomical system involved in any symptom analysis: vision, vestibular, and sensation. So, functionally, vestibular apparatus forms the key to the system of balance. It has significant connection to the vestibulo-ocular, vestibulo-spinal, and vestibulo-cortical and vestibulo-cerebellar connections. Because most of our diagnostic approach are based on the connections and not the exact anatomy. An assessment of balance, clinical and electrodiagnostic methods can be used. Eye movements form the key to assessment of the balance. This is a video histogram view of an abnormal eye movements, which we call nystagmus. There are several types of nystagmus, and we as of now assess this using only our vision, our own native vision. And this is this is a very huge shortcoming for us. If we have the support of video histogram, we can document and analyze eye movements better, thereby finding a serious pathology causing giddiness. Another test we use is a head impulse test, which again is very specific test but not a sensitive test, and very difficult for us to observe little movement that happens during the test, where a technology can support us in a large way. Another thing we do is assess the patient's posture, closing the eyes, opening the eyes, ask them to stand in a step on the same place, walk in a tandem. Another thing is a gait analysis. So in terms of ornamentally for diagnosis of imbalance, we are left with very little things, and it's a rather specific but very insensitive for an accurate diagnosis. And most of these clinical tools are quite subjective and they are not quantifiable. So in terms of the technological test to help in assessment of giddiness, we have Fresnel glasses, video head impulse test, electronystagmography, video nystagmography, and rotational test to assess the vestibulo-ocular function. You can have a craniocarpography for a vestibulospinal assessment, and vestibulo-cortical assessment, vestibular myogenic potential, and beam, which is a brain electrical activity mapping, which we have. And vestibulocerebellar predominantly assessed using a neuroimaging assessment. These two components we have. We are quite short of instruments and expertise in these vestibulo-ocular evaluation and vestibulospinal evaluation. And more importantly, another important system that evaluates the function of vestibulo-ocular, vestibulospinal, vestibulocortical, and vestibulocerebellar function, the computer's dynamic photography, which we don't have. Vestibulo-ocular function is the simplest of the equipment. It consists of a magnifying glass and a lighting system. It prevents the patient from seeing outside, where we can see the patient's eye, as illustrated in this picture. It can be optical present where we directly see, and more advantages will be to have a video Fresnel where we can closely monitor the eye movements. We can record it, and we can play it in slow motion, and we can have more detailed analysis of it. And people have come up with modified or customized VR glasses in terms of Fresnel glasses, because Fresnel glass, though such a simple equipment, it's not available widely. And video head impulse test is again uses an instrument which records eye movements and analysis, computer analysis based on it. Electronistogram detects eye movements. The change in the cornea retina potential during these movements are recorded, and these are picked up by the electrodes located in appropriate position near the eyes, and this can generate a graph from which we can analyze and find out the cause for patient's imbalance. Video nystagmography is the best of the equipments available for analyzing the vestibulo-ocular function. Rotational stack testing useful in certain patients. It's again a huge equipment. The patient is seated in the chair, blindfolded. We use the electronistogram to record the eye movements here. Gain phase symmetry of the eye movements are studied to come to a conclusion of what is causing the patient's imbalance. Vestibulospinal tract evaluation, we use craniocarpography. This particularly evaluates the system. Here, visual and proprioceptor inputs are eliminated. This is basically an older version of it. A photographic record of head and body movements are made. A convex mirror is there. Adjustable camera and helmet with lights is there. And the patient is analyzed during their stand-up walking, and stepping. This can differentiate between a central and peripheral cause. And newer versions of this include an ultrasound-based system and a gyroscope-based system, which is very simple to manufacture, but which is not available widely. And this is the most advanced equipment we can have for assessment of a patient with imbalance, because this assesses balance as a whole. This is the only method available so far now that integrates contribution from vestibular, visual, and the sensory system. It also functionally evaluates the postural ability, but it does not locate the site or the cause of the lesion. It affects all the components of the balance system, including the vision, proprioception, and labyrinth, and the motor component of it also, including the long loop pathways, the individual skeletal muscles. This is how a computer-based dynamic postography looks like. The test done by this includes sensory organization test and motor coordination test. This uses different algorithms, depriving the patient of one or two or all the sensory stimulation, and assesses how the patient maintains the balance. And putting the balance to test using the forward and backward translation of the base, a toe up and down rotation to assessing how the patient can compensate for the imbalance. This is rather a highly sensitive test for central pathologies, both vestibular and non-vestibular. It assesses the integrity of the CNS when the three sensory inputs send in a contradictory information, which happens most often. To individualize vestibular rehabilitation exists, this is quite useful. To summarize, for a neurophysician, we need certain equipments which are already available, but we don't get it easily in our part of the country. Pencil classes, the simplest equipment, video head impulsive test, electronystagmography, and video histography, all can be more or less same equipment. A video histography is more superior to all those things. And craniocorpography, which assesses the vestibular spinal function, and the computerized dynamic postography. We request the engineering community to make these things available to us, get it in a standardized safe way, and make it more affordable. Thank you.
Thank you so much for an interesting talk about nystagmus and all. Now, may I invite Dr. S.P. Tirupati for his presentation, please?
You are in mute, sir. Dr. Tirupati, sir, you are in mute. Please unmute your mic.
Okay.
Yeah.
Am I audible now?
Yes.
Yes. Fine. So I'll share my screen. My screen is there?
Yeah.
Yes.
Yes, fine. Thank you. And whole screen, just a minute. Okay. Can I start, sir?
Yes, please.
Yes, please. Thanks for the opportunity from Sastra University. And my previous two colleagues of mine have touched upon the technical aspects, what we need, and how it is very determining for the patient care. Now, yes, I will just, since they have made my job also easier for initial few slides, and how to execute out the Indian concerns what are there, which is where I want to have a holistic view on this. So always, before technique and technology is always a tug of war is there. Tug of war or hand in hand, which supersedes which at a particular point of a time, always a question lies. So as Ramesh said, it may be for neurosurgical perspective, it may be a mechanical or microscope, which is, and some videos. I don't want to go into that because he's already on endoscopies. And sometimes we need electric or pneumatic drills, which speed up our process. Example, before we used to have open the skull by make it of 1 hour. Now it takes hardly 5 minutes. 5 minutes to entirely open the skull. Okay. Okay, I think we can. Just to, I want to show us what we do about this. The opening the skull takes hardly 5 minutes now, which saves a lot of time and golden hour period to deliver to our patients. Okay, again, and we also thankful to our colleagues, neurology colleagues, who enhance the safety to our measures with the intraoperative electrophysiological monitoring, which is now becoming order of the day. Yes, the cardinal principles of governing the ethics in healthcare is benefit, and more than that, do no harm. That is the basic governing ethical principle in healthcare, which our techniques and technology to adhere to it. That is more vital importance of it. So that ensured the development of micro instruments, better hemostatic equipments, hemostasis area. See, the healthcare professionalism over the years, it's evolution. First as a primary care, then general care, then specialization, then super specialization, now subspecializations. Now we are moving to the year of subspecializations, like a joint replacement surgeon, not as a neurosurgeon, skull-based surgeon, or endoscopic surgeon. This is the scenario which we have to keep in mind. And the standard of care is being imposed. It has to be adhered to all hospitals like NABH are there nowadays. And we have to look into this. Please understand, the average lifespan of an India in 1947 was 31 years. Now it is almost 2015, it is 68 years. And as neurosurgery, when I start my career, everybody will say that because the results were bad in the olden days, if you have a head shaven for you, next day the son has to shave his head because he has to find the rituals. That was the saying, it was there. And another thing, the paradigm shift in healthcare scenario is before the deaths were happening at the home, and at present date, any death, everything is happening in the hospital. No death is happening in the home. This is another changing scenarios. And the multi-pronged healthcare delivery have the options where techniques and technology has to fit in is maybe the diagnostic, preventive, therapeutic, palliative, rehabilitative, training, and multidisciplinary approaches. See, as a neurosurgeon, the technical technological adaptations may not be per se to neurosurgery alone. We have adapted from our allied disciplines, from other interdisciplines and extra disciplines also. So it need not be focused on that. For example, allied disciplines, yes, radiology. Without radiology, development of radiology, neurosciences and neurosurgery would not have gone to this extent. So we do myelogram now, MRI. I don't know, I'm just rushing through these slides. And we have now 3D imaging to have a beautiful 3D imaging to have a beautiful surgical plans. Okay. And we get into a 3D subtraction angiographic imaging is going on. And we have 4D CT, which they have synchronized with the ECG monitor. And this is one going on. An endovascular ultrasound, MR tractography, stereotaxy, yes, what not. An interdisciplinary. See, Dr. Ramesh showed a hydrocephalus treatment of the endoscope, which was adapted from the urological side. Urological side, not from neurosurgical side. And this is endoscopy, nasal endoscopy, which we have extended from the ENT side. Okay, fine. Next, extradisciplinary. Yes, where? See, thermonavigation. This principle which was adapted from the military services. And you say the navigation, what Ramesh also showed of the navigation, it was adapted from the rocket science, satellite global positioning system. It was adapted into the neurosurgical field. What I said, and implants, particularly when we, in the olden years, we are using only steel implants. Titanium implants were not present. It was only imported. It was very, very highly costly. Then what happened is our ISRO, our rocket science people had the enormous stock of titanium. And with the vision of our erstwhile President of India, Abdul Kalam, he opened to the medical market. Suddenly the prices came down. Nowadays, the steel implants are being obsolete. Now it can get to a very cheaper price. So, which we are using day and out. The spine surgeon is there. And so some potential scopes I want to highlight before getting into the crux of the situation. Neurotrauma, yes, because increased motorization, Indian scenario, high velocity, there is a high motorization, and the attitude of the people is also going deteriorating by day. Now, we have to concentrate on aspects where biotechnology are useful in preventive aspect rather than treatment aspect. One. And bionics, it's a beautiful, very, very important order of the day. Bionics. Hope you are well aware. With short time, we need not to explain on that. And the important area is the rehabilitation. Rehabilitation area, there's a huge ample opportunities are lying on the rehabilitation side, where biotechnology can serve as a biggest player, right? Then see example, a bathroom designed for a disabled. This I witnessed when I was doing in Japan fellowship there. The smooth bathroom for a disabled persons. This may become a huge difference in patient care. And surgical comfort, as chairs, you can give comfort to the surgeons. Like the surgeon, okay, just I'll show. He has a control of everything. It's not running. Okay, it's okay, fine. A person can sit in this chair and sorry, my slides are getting. I have to come again, please. I have to come again, please. 1 minute. Close the program and come again. Just bear with me 2 minutes, please. I'm audible?
Yes, doctor.
Please, 2 minutes, 2 minutes.
Yeah.
Some way. Okay, fine. Screen share. Okay. This is a problem. Technically, very weak, you know. Technologically, fine. Okay, fine.
Seems doctor got disconnected. Dr. Anuradha, seems doctor got this. I mean,
Yeah, I'm calling him.
Yeah.
Sir is logging.
Logging in.
Hello, Dr. Tripati.
Hi, yes, I'm there. Sorry, some technical issues. Sorry. Okay, I'm there.
Yeah.
Okay, I'm to start my screen sharing, please. Okay, my screen is there, madam, please.
Yeah, sir.
Sorry.
Screen is visible.
Sorry. Something technical. Okay. Okay, then there's always a very scope for home care, networking, and telemedicine in these aspects. And you can have simple applications. Like these patients are tend to tie their hands in the irritable patients. Simple solutions can also add to their thing, and simple add-ons can also be there. And training, there's a lot of scope where for medical training where this biotechnology can pitch in here, like biomodeling, what you call a stereolithography. You can biomodel their structures exactly to have a training models or surgical preparations. And there's also a good scope of artificial intelligence over here where our moderator is well versed in this. See okay. Now, healthcare outcome is not now just life. People want some quality of life. That is the biggest shift which we are in the era of that. See, when I was a young child, I used to see advertisement for population control. Now there is advertisement for infertility. That's a paradigm shift of healthcare scenario. More than disease, now treatment is being sought for, medicine is being sought for lifestyle alterations like hair transplantation, breast augmentation, and all. So that you have to think, these are the things, these are the opportunities where we can lifestyle modifications from 3D model implants can be used in neurosurgical things. And there's increasing awareness about the disease prevention, lifestyle, information, data, and law. And we are in the era of globalization and consumerism. In this area of globalization, everything is available. The problem is how we can make it affordable to everybody. That is a key. See, available, it's both ends, to the provider and as well as the consumer healthcare. Both has a problem about availability. Yes, that is not easy. That is easy. Now it becomes easy. Accessibility, yes, it is becoming easy. And that is affordability and adaptability is a major cause of concern here. Because the instruments should be a break even for the provider. If it's not break even, the consumer has to bear the cost and becomes a liability to the entire healthcare scenario. So the rising cost of healthcare because of expensive new technologies, costly new treatments, and aging of the population, and growing expectation of the public and also attitude of the physician. This is a social climate which you have to understand when applying these gadgets here. See, there is one thing called out of the pocket expenditure. The global is 45.52%. In India, the people tend to spend from their pocket around 89%. That is the biggest impending factor what we have to face here. And how to have this value? This is a simple formula which is being proposed. A value of any technology or technique is equal to quality plus service divided by cost. That is how a value of an equipment or technology or technique is being valued. And another biggest thing, we are in the era of obsoleteness. See, we used to have some camera, the camera with a film roll, which is expensive. Now it becomes obsolete. And we have seen the area where we have seen what you call as pager came and became obsolete. And this is the first time in the human history, this generation, in our lifetime itself, something is coming up, and immediately it is also falling down. So where we stand? The area of obsoleteness is not only for instruments, for scientific knowledge, newer technologies, implants, equipments, and methodologies also. So this is important parabola, what is called a Scott's parabola. I want you to have a deep look into this. See, it always starts, just I'll spend some few time in this parabola. First, any technology or technique or everything comes to the promising area. But first as a research tool, then some encouraging reports, grooming. Then there's a widespread enthusiasm is always there. Then the strong media pressure for universal acceptance is there. Then it comes to general introduction to the market. Then it becomes a standard of care. After standard treatment, some doubts creep in. So damaging survey reports coming in the way. Then widely publicized medical legal cases also there, and condemned by several authorities. Then used only for highly specialized circumstances, falls into disuse. Sometimes operating theatre staff ponder what is the use of this equipment, and some old surgeons will always otherwise going to the station about the old stories. So we have to always be within this parabola to see whether relevance of our technology or technique. I want everybody to know this parabola to know where we stand, where we are viable or not. And so other thing, the Indian scenario is better health is through better use of the resources. We're making use of the basic value of framework for healthcare system and proposing openly principle on which priority should be based on dignity, solidarity, and cost effectiveness. See, acute care is essential everywhere. It has to go everywhere, percolate every nook and corner of this country, because golden hour treatment is essential. There's a big urban-rural divide, but the transportation facilities are being enormously improved, so the time travel has come down a short. So, how to beat this? I propose health model where, except for acute care, we ought to develop a centers of excellence where we can pool all the scientific technology, techniques, everything like transplantation, joint replacement, centers of excellence, or a few centers of excellence where we can pool all the techniques, technologies, everything, and high volume centers where the expertise also develops, and we can have a scientific pool of scientific data, and we can be global leaders because of a huge population, human resources. And this becomes what happens is the equipment becomes, the viability and break-even becomes easier. The overall healthcare becomes very, very cheaper to everybody and viable. It is a win-win situation, which I request the authorities and the students, everybody to think in these lines. I won't say this is one solution. This is my proposition and perspective in this regard to ponder upon further on this. See, another thing, judicious use of the equipments. When all you have is a hammer, everything looks like a nail. And a fool with a tool is still a fool. That is also very, very important, which we have to imbibe in our knowledge acumen. And that's where the scientific acumen, original research, and what a previous speaker mentioned, some innovation has to be there, considering not only the technology advances, social circumstances, obsoleteness, the viability, long-term values, cost effectiveness to the healthcare provider and the other consumer. And learning is always a process of learning, unlearning, and relearning, and also what to do and what not to do. And another thing, we also should have a point on ancient wisdom. Okay, so I want to quote an important thing, or paper which we presented at the CNS Congress at USA, where one observation, interesting observation was there, the plagiocephaly, there is a abnormal head shape, which is more prevalent in the US population. But it was not at all happening in Indian population. So they were formulating important things like helmets, which is costly, millions of dollars. They are spending to shape the head, everything, reshape the head of the children. And what we found is the NRA population who come to us, they had the same problem. And they were asking me, sir, can you get me a helmet for these children? The helmet has to be worn by the child, 1-year-old child, for 23 hours. Less than a child, 23 hours has to be worn. That was a proposed statement without good evidence base also. And it was a heavy, huge cost. Then we were thinking, where? So why does our population doesn't get? Only why this particular population is having this? Then we had a thought process. What we found was those people who are put in the children with a flexible head were put in the cradle, cradle of sorry. What our Indian people are putting in this, what is called a thuli, where the gravitational forces acts equivocally. And we presented this with presented with one Dr. P. Kali, a retired professor of biophysics from Bharatdas University. He learned about the gravitation, how gravitational forces acts upon this, how circumferentially the gravitational force acts upon the head. When you suspend this from thuli, yes, some concerns about safety measures are there. And we have adopted some techniques like having some wooden plank to avoid any suffocation also. Still, if you could put some scientific research and something more to it also, some safety equipments to this may be a game changer. And it was accepted in the USA and all India international conference. The apex body accepted this as a simple solution to this plagiocephaly problem. And I am very, very proud to say that the word thuli has been accepted in the scientific terms, scientific terminologies, and some course correction in that. Another, moreover, there is a Harlow's experiment is there, which shows that they were doing with a monkey where there is always an emotional attachment with the mother's clothings, and it was near a Nobel Prize. But what we do traditionally here is, see, we use this thuli cradle with the mother's sari, which has increased the emotional attachment also. So at one simple solution, which we can have a solution for the condition called plagiocephaly, and also the emotional bonding with the mother. With some further small adjustments, we can be a big game changer. This ancient wisdoms also has to be taken to the global level, which is my request. This is one example. It's not technology with technology. It should be go hand in hand. So the working principles and methodology would be economics, equipments, time, goal, and place, all put together with a thought with beautiful clarity. This is not of the scientific temper. It was from our age-old Tirukkural. Porul, Karivi, Kalam, Vinay, Idanodu, Aindum, Irul Thira, Enni Chayal. Thank you.
Thank you so much, Dr. S.P. Tirupati, for sharing your thoughts and thought-provoking for innovations rather than copying. So, can I share my screen?
Yes, sir.
I share my screen with you? Yeah. So, I want to, enumerated all the things here to summarize, but would be a little bit more interested in talking about artificial intelligence. A lot of people have spoken about artificial intelligence and what is the application to the medical world and all. We all, as a doctors, as a surgeons in various specialty, we always want to help people. But down there, over the n number of years with successful cases and all, there is an element of God complex which creeps into us. And most of the surgeons, they think that they are the best in what they are doing, and there is a lot of eminence-based practice rather than evidence-based practice among the doctors across various specialty and all. And it's a complex. When you get all the tools with you, you still feel that you will be able to perform all these surgeries in a better way, um, and all. But being a surgeon talking about an artificial intelligence, a lot of people will think that we are all oxymoron people who don't understand anything about that. So artificial intelligence in medicine, it has got two applications. One is the virtual, the second one is physical application. Virtual, most of the engineers, they deal with it. They have some kind of machine learning or a deep learning or a neuronal network with mathematical algorithms and all. Trust us, most of the surgeons, they are not into mathematics or algorithms at all. So it is up to the engineers to calculate all these things. We have to give a feedback in terms of diagnosis. Like, for example, I pick up a particular disease, I will enumerate all the symptoms, and we should have a database so that whenever we enter all these symptoms, by the virtue of artificial intelligence, we have some kind of diagnosis available with us. So that is one aspect of the artificial intelligence. Now it's a time to take it a step further, like physical. We were talking about the mixed reality or augmented reality. They are all the same, and we need to use this artificial intelligence to create objects or medical devices, or maybe integrated with the robots, so that we can use them better. And so this is one example. This is with the HoloLens. What you can see, I have projected a holographic image of the X-ray over the patient's hand. I exactly know where my fracture is. I give a small cut, and I can fix a fracture without being worried about damaging more structures and all. So this is all projected on my HoloLens frame, which I am using it as a headgear, and I can do these kind of surgeries. So I am projecting all my X-ray images, MRI images on the patient in the real time. And well, I am performing this surgery. This can be transmitted to another surgeon in the virtual world, where the surgeon can download, or where the surgeon can see everything. If he gets stuck up in some particular step or anything, then probably the other surgeons can help him out. Uh, the next one is the next application would be to record all this procedure, and you can, if your patient is really interested, then you can show these procedures to them. And also it keeps the record of the surgical procedure for the medical legal purposes in future. So this is one of the applications of artificial intelligence with mixed reality. We have these goggles with us, but unfortunately they were all designed and developed with the help of Microsoft Unity platform. So we don't have any of the Indian tech with us. So in terms of improving the technology, it's not only the copying the concept which the other Westerner world are doing, but it's also to create something for for our own people, by our own people. Because a lot of surgeons, they get stuck up in some position or in some steps. They feel that, oh, I should be having this kind of instrument or that kind of instrument. So here, the engineer should converse with the surgeon and sort the issue out. There will be a lot of failures in the early stages, and from the failures only we all will learn. So this is another example. This is an lumbar disc replacement device. It's a single piece monoblocks. It's an integration of the titanium end plates, which you can see very clearly on the X-ray. And in the cartoonified image, you can see it's a polycarbonate urethane with it. But the beauty of this device is nothing is welded. Everything is vacuum sealed. So, and they have been subjected to around 40 million cycles in the lumbar spine in a lab environment, which translates to around 60 to 80 years of human lumbar movements. But unfortunately, not many people have designed, were very successful with these kind of designs and all. There are only few companies which can do that. Unfortunately, they are designed in European country. France was one of the country which invested a lot. We don't have this kind of investment or innovations in our country. So maybe somebody could take up this project. Um, and yeah, so coming to the summary, uh, with all the presenters and whenever an engineer interact with any of the physician or the surgeon, you will see that there are a lot of things which are required in our country, but most of them, they are not manufactured or they are not designed in our country for our population. From a simple screw to the highly advanced robotics or navigated things, we don't have anything. We don't have our own system which has been developed in our country for intraoperative Doppler, navigations, robotics, MRI scanners, CT scanners, microscopes, drill. They are not. We have to be dependent on some other company across the world to get them. Simplest of the simplest thing which Dr. Ramesh has highlighted is aneurysmal clips and coils. uh, yes, they are very simple things. And somebody in the audience, they asked me about what is the material. It's a titanium. It's a grade 1 titanium. Ti 4Al6V is the alloy. And somebody asked that, is it possible to do a 3D printing? No, it's not possible to do a 3D printing for this aneurysm clip or coil, because the surgeons can't afford that these things will break. They should have some kind of flexibility, and they should do their purpose, because it's the patient's life which is at risk by doing this. 3D printing can help you in designing the clip or coil according to the Indian patient needs and or sizes and all. So a lot of things, fusion cages, disc replacement devices, the preventive software or preventive things to prevent any kind of sort of accidents and all is a very good idea. I'm not sure how the algorithms or the programs can be made, but until unless we try it out, it's very difficult to say that this will never work. So we should be ready for innovations, and ready for our failures. We should learn from our mistakes. And it has to be a lot of surgeons, there has to be involvement between the surgeons and the engineering community, and they have to work together, right from the high volume centers and all. Unfortunately, we don't have our own artificial, the knee joint replacement device. There was one Indus knee which was designed around 12, 13, 14 years back by one of the institutes in Pune, but it failed miserably. But the design was never improved. It was there. It's kept on the shelf now, but nobody came forward to improve that design further. So there has to be a good tie-up between the engineers and the bioengineers, what I say, the spine surgeons or the neurosurgeons or any other reconstructive surgeons. I call them bioengineers. So the bio and engineers, they should come together to improve the technology. So any questions?
So, if there is no question, so I will conclude by saying thank you to all. So it was really a very wonderful virtual meet and very insightful panel discussion, I should say. And sure, doctor, because at Shastra we have a bioengineering department where the major objective is to bring the flavor of this biology to the engineering community. So because that is the one thing that we need to now look into in order to get a strong and a more affordable, healthy India. So, so I extend my special thanks to neuro experts who have provided all valuable inputs to our participants. So who are the future entrepreneurs. So because most of the participants are from research community, student community, and also young minds. So they will definitely take all these informations, and definitely I'm sure it will definitely stimulate the young minds to enhance the medtech capacity, especially in terms of developing various surgical tools, as you, Dr. Ramesh sir mentioned. So many of the small accessories, which even we have to rely on other countries. So now I think some of our innovators can take up this chance to identify the areas where we can contribute more to manufacture these surgical items in India, so that we will actually cut down all the costs and it's more affordable to every people across the country. And also, I'm very sure that now, like this artificial intelligence and 3D printing is also coming up. And at Shastra, we have an A+, we have all the facilities, 3D printing facility, virtual reality facilities, and now many young minds are also involved in understanding this artificial intelligence and trying to get their interventions, especially in early predictions. In fact, you can also predict the disease even before it occurs. So there are so many other important avenues now with us. I hope this will be a very useful session. And I'm very much thankful to all of you who have participated in this virtual panel discussion. I'm definitely sure you all have made this event a grand success. So thank you very much. Thank you all.
Thank you, Anuradha. Thank you, Dr. Swaminathan. And thanks,
Thank you,
everyone.
sir. Thank you.